I think we are ready to start. We had some technical problems, but already managed. Welcome everyone. Good morning, good afternoon, depends from where you are watching us. I would like to warmly welcome you on this seminar. It's the first seminar of the NeuroEYEscience group. In the beginning, I would like to really thank to Worldwide Neuro for making it possible to join the seminar's organizations. And especially I would like to thank to Tim Fogels, who personally set it up and organized everything from the technical side and also from the side of the topic choices and all the scientific aspects. Today, I would like to welcome with us Professor Dorota Pojda-Wilczek. Professor Wilczek is chair of the section of neuroophthalmology and electrophysiology of Polish Ophthalmology Society. And she's also working with electrophysiology topics over 30 years. She's one of the leading experts in this topic. And I would like to thank to Professor Wilczek very much that she agreed to give this seminar, this speech about electrophysiology application for optic nerve and central nervous system diseases. Before we start, I would like to tell a little bit about our rules. So the seminar will last about 1 hour. And all the comments or questions that you will have during, if you would just type in this live chat on YouTube channel. Additionally, if you have any questions which are not directly related to the seminar topic, or you would like to ask about something more, there are also 2 email addresses which I type in the chat. One is our NeuroEYEscience email address, and the other is email address of Professor Wilczek. So I would like to wish you a good seminar. And now, Professor Wilczek, let me ask you to start. So the topic of today's seminar, electrophysiology application for optic nerve and central nervous system diseases.
Thank you, Dr. Smendowski. Hello, everybody. This is a great honor and privilege to be invited for this seminar. Let's start. This is very important to remember that visual stimulation activates at first a retina with its multiple connections and cellular interactions. There, at the level of the retina, start various pathways responsible for the transmission signals to the numerous centers in the brain. The visual pathways may be regarded in general in 2 main groups: pathways for vision and pathways for reflexes. Although they both start in the retina, they terminate in completely different brain centers. That is why we shouldn't estimate vision by tests based on reflexes. Regarding electrophysiological tests, there are limitations as well. The tests are applicable for the pathways for vision, but not for the pathways for reflexes. Pupillary reflexes, optokinetic nystagmus, saccadic movements, and so on may be evaluated using the other procedures. But going back to the vision, as far as electrophysiology of vision is concerned, we may follow visual stimulation transmission from retina to V1 cortical area, that is 17 area according to the classification introduced by Brodmann. Nevertheless, from the primary visual cortex, the visual signal is conducted to the next areas involved in visual processing for its evaluation, understanding, remember, and reaction. These higher visual functions cannot be directly evaluated. Function of the retina is measured by numerous procedures: electrooculography, electroretinography with its modifications, but today we start with only one subtype of retinal cells, retinal ganglion cells. Retinal ganglion cells are the first cells in the visual pathway which generate active potential. The active potential is transmitted via cells neuritis, which form optic nerve, optic chiasm, and optic tract, to the lateral geniculate nucleus in the thalamus, and from it via cortical radiation to the striate cortex. The function of ganglion cells may be checked by photopic negative response, the modification of flash ERG, or by examination called pattern ERG. The final cortical response to visual stimulation is called visual evoked potential and may be evoked by pattern or flash stimulation. When we look at simultaneously registered ERG and VP, we clearly see the connections between the retina and the visual cortex. Electrical response to the light is conducted to the brain. As you see after stimulation 30 Hz, it may proceed in various modes. In my opinion, this difference may depend on age, as you see here. In the younger patient, every signal from the retina reaches visual cortex, while in the older patient, every 3 retinal activations form the cortical response. About 50 milliseconds is required to produce active retinal potential after light stimulation, and another 50 milliseconds is required to reach the visual cortex. In transient pattern ERG, 2 main waves are analyzed. P50 wave originated from central retinal ganglion cells and the other retinal cells and photoreceptors connected to them, and N95 wave, which reflects the activity of retinal ganglion cells located peripherally to the center. Standard transient pattern VP are evoked by checkerboard with check sizes 1 degree and 15 minutes. The shape of VP is similar. VP after smaller checks reflect function of the macula. Between visual acuity and amplitude of P100 wave exists strong correlation. VP after larger checks are connected to pericentral area, and abnormal results after this stimulation usually coexist with visual field defects. In pattern VP, the most interesting wave is called P100. Abnormal latency of this wave results from abnormal function of any element of visual pathway, while lower amplitude is a consequence of less than normal number of cells or connections. Pattern stimulation enables to examine macular region. The shape of pattern VP curves is stable and comparable among various subjects. Amplitudes of P100 15 minutes and P50 and P100 1 degree and N95 are correlated. Flash stimulation is much more complex and individually variable. This creates problems with analysis. Flash of light stimulates all retinal photoreceptors. Flash VP is a generalized answer from all visual systems elements. You see the differences between pattern and flash VP, although the shape is generally similar, with negative and positive waves caused by deflection of visual pathways and transmission of the signal towards and backwards the occipital electrode. In a flash VP, the highest and the most stable wave, the P2 wave, occurs about 100 to 130 milliseconds and comes from the activation of primary visual cortex, V1 region or 17 Brodmann's area. What about the other waves? Based on indirect observations, we suspect that N1 P1 complex probably reflects the activity of anterior visual pathway from retina to geniculate nucleus. No doubts that P2 reflects the activity of V1 area, maybe also areas V2 to V5 as well. P3 wave comes from occipito-parieto-temporal region and is called associating wave. This wave probably reflects higher visual function. But we have to finish the introduction and pass to the point of the seminar, that are visual problems related to abnormal brain function. I divided them into two main groups, the diseases of anterior and the diseases of posterior visual pathways. The former ones are mostly limited to the optic nerve, and the latter comprises generalized brain diseases. The most common optic neuropathy is attributed to glaucoma. In early and preperimetric glaucoma, Patternier G is the most variable examination. Reduction of N95 amplitude is the first sign of optic atrophy. In advanced optic atrophy, both P50 and N95 waves are extinguished, like in this example of advanced optic atrophy in the right eye and early stage of optic atrophy in the left eye with reduction of N95 only. This is exactly the opposite to early macular dystrophy with reduction of P50 and preserved N95. While in high myopia, coexisting macular degeneration and optic atrophy may cause changes of both P50 and N95. Patternier G may be useful in follow-up in doubtful cases. Sequential examination may reveal the first signs of progression, like here. It's examination year after the first. In advanced glaucomatous atrophy, pattern VP are abnormal even if visual acuity is normal. Estimation of visual acuity in a case of advanced optic atrophy cannot be based on pattern VP then. In this case, flash VP were delayed and reduced until intraocular pressure was effectively reduced. Enlargement of P1 amplitude followed by enlargement of P2 amplitudes are visible signs of functional improvement. Similarly, successful glaucoma surgery may improve optic nerve function. It is seen as enlargement of P1 and P2 amplitudes of flash VP after 3 years. In the case of congenital glaucoma, the trace function of the right optic nerve and no function of the left one are seen. In the case of juvenile glaucoma with good visual acuity, the differences between eyes indicate that more advanced optic atrophy affects right optic nerve. In advanced optic atrophy, flash VP, which normally are composed of numerous peaks, became flat, like pattern VP. In multi-channel VP, registration of differences between crossed and uncrossed uncrossed and crossed fibers should be observed. In this case, lower P2 amplitudes are seen in uncrossed portion of optic nerves, what corresponds with optic atrophy of temporal parts of optic nerves. Abnormal uncrossed flash VP is not a specific sign of glaucomatous optic atrophy. It may be attributed to various types of optic atrophy or another inherited condition, the albinism. In some cases of albinism, optic chiasm comprises more than half of all nerve fibers from each optic nerve. This causes lower P2 amplitude from uncrossed parts, but higher than normal from crossed ones. I recommend in these cases to use mean amplitude from crossed and uncrossed fibers to exclude optic atrophy. In doubtful cases, follow-up VP is recommended as well. Look at the differences among abnormal fibers distribution, optic atrophy of uncrossed and crossed parts. The last example of flash VP shows delayed P2 latency and reduced P2 amplitude from crossed fibers because of optic chiasm compression by tumor. Hereditary optic atrophies have their own pattern. Kier's type atrophy affects first the temporal parts of both optic nerves, and it causes reduction of P1 amplitude. Leber's type of optic atrophy affects optic nerves totally, but not at the same time. The differences are seen between eyes, not between the crossed and uncrossed parts of the optic nerves. Hypoplasia in visual pathways may be limited to one optic nerve or its part, but more often occurs bilaterally. In this case, hypoplasia of left optic nerve is accompanied by hypoplasia of the temporal part of the right optic nerve. In this case, total blindness of the right eye causes no differences between binocular here and left eye flash VP. And the same you see here in this example. In developmental defect of the brain, hypoplastic left optic nerve and left part of the right optic nerve cause characteristic change in flash VP. This is a picture of left optic nerve and left optic tract hypoplasia. Look carefully at these curves. They are running up and down, but they do not reflect visual activity. This is alpha written. The eye is irreversibly blind. Additional proof of this fact comes from flash ERG, which is supernormal in the blind eye because of absence of downregulation from the brain. The alpha rhythm becomes extinguished with time, as you see in results from another patient 16 years after the trauma. VP have no prognostic value immediately after a trauma, as you see in this case. In the beginning, flash VP were quite good in both eyes. Flash ERG, immediately after the trauma, shows only little differences between eyes and may help to exclude traumatic retinopathy. Final outcome of the trauma is seen in VP after about 3 months. Craniocerebral trauma may cause optic tract lesion, clearly seen not in all electrophysiological procedures. In this example, after pattern VP examination, right eye seems to be intact, but flash stimulation revealed abnormal function not only left low vision eye, but whole visual pathway in the left brain hemisphere. This is seen after right eye stimulation from the left hemisphere. It's abnormal, and from the right side, it's normal. In this case, flash ERG is normal because left optic nerve is not transected. On this slide, the differences between optic nerve lesions and visual pathway lesion in one hemisphere are compared. Compressive optic neuropathy may be due to a number of factors. In this case of craniopharyngioma, the first sign was sudden visual loss like in bilateral retrobulbar optic neuritis with delay latency of P100 and P2 and decreased P100 amplitude. In this case, optic atrophy was caused by orbital abscess. Flash VP is delayed and reduced, but still present. After a few months, it became extinguished. In this atypical case of Graves' disease without exophthalmia, compressive neuropathy started with signs of optic neuritis and was accompanied by high intraocular pressure. Despite of low visual acuity, only little signs of optic atrophy are seen in flash VP, and after the treatment, full visual acuity recovery occurred. The last patient had typical clinical signs of anterior ischemic optic neuropathy, but markedly abnormal and delayed flash VP were found in both eyes, and computed tomography revealed pituitary tumor. Solid tumors like meningiomas may lead to marked vision loss and optic atrophy without edema of the optic disc. Delay P latency is one of the most important signs of compressive neuropathy. In the case of asymmetric optic chiasm compression, delay latency and abnormal amplitude may give clinical picture of unilateral optic neuritis. Like you see here, in both present cases, the signs of crossed fibers compression in optic chiasm are seen in pattern VP. Compare this picture with prechiasmal lesion of only one optic nerve. Removal of a tumor in some cases may be followed by complete withdrawal of the signs of compression, or P100 latency may remain delayed, as you see in this case of orbital hemangioma. Look at the examples of flash VP in tumors of optic nerve, optic chiasm, and brain. Abnormalities in prechiasmal lesions are limited to the one nerve. In chiasmal lesion, change are seen as abnormal function of crossed fibers, while in large chiasmal and post-chiasmal lesions, flash VP are extinguished. Anterior ischemic optic neuropathy is usually accompanied by low visual acuity, and pattern VP is extinguished, like here and here. In flash VP, decrease of P1 and P2 amplitude is common. Delay of the latency depends, in my opinion, on how long and how much the optic nerve is swollen. Lowering of P1 amplitude indicates that the disease originated from anterior part of the visual pathway. Look and compare P1 amplitude in affected eye. In cerebral ischemia, we are looking for the differences between the left and right visual pathway. Delay latencies and decreased amplitudes of P waves on the side of the stroke, here on the right side, are observed in pattern and flash VP as well. Interestingly, little differences of amplitude and latency of P1 confirm the disease of the posterior part of visual pathway. Cortical ischemic lesions caused extinguished flash VP, but in some patients with cognitive defects rather than optic atrophy, pattern VP may be used for visual acuity estimation, and you see here the answer. The patient is not blind. This is important for further vision therapy. In active optic neuritis, diminished pattern VP with delay P100 latency is observed. In remission, visual acuity and pattern VP may be normal or delay. In multiple sclerosis, delay P100 latency is usually found in both eyes, even if acute optic neuritis affects only one of them. The P100 latency in affected eye is longer and the amplitude is smaller than in the fellow eye. Lower P100 amplitude after stimulation 15 minutes and the much less affected result of stimulation 1 degree are better prognostic value than abnormal visual response after both 15 minutes and 1 degree. In that case, the outcome is usually worse and the optic atrophy occurs. Web-enabled observation of optic nerve function and early diagnosis of optic neuritis in doubtful cases. In this case, optic neuritis occurred 3 months after the first visual problems. The first VP were normal, but when visual acuity decreased, the P100 amplitude became lower and latency longer. You see the evolution of optic neuritis with worsening despite of the therapy and final improvement with normal visual acuity, visual field, but a little lower amplitude than at the beginning. I have known this lady since 1990s. Despite of disseminate sclerotic lesions, her visual acuity is still good, and she has no optic atrophy. Delay P100 latency may persist after optic neuritis. Smaller than normal P100 amplitudes of pattern VP with good visual acuity indicate partial optic atrophy. Flash VP in this patient confirm left optic atrophy. Look at the flash VP of another patient with optic atrophy after numerous optic neuritis in course of multiple sclerosis. This flash VP look like pattern VP. Visual acuity is very low. Intracranial hypertension without visual disturbances may not affect VEP. VEP procedures help to differ among inflammation, ischemia, and stasis in papillary edema. However, long-lasting intracranial hypertension may cause delayed P wave latency and a decreased P wave amplitude. In this case, the differences among examinations before treatment and after treatment are described, but they excellently correspond with visual problems and improvement after the treatment. To make therapeutic decision, I recommend to observe in flash VP not only P2 waves, but all negative and positive deflections to find small changes. Encephalitis may cause transient or persistent changes in amplitude and latency of VP, and the examination is recommended in follow-up of the patients. Abnormal flash VP in Alzheimer's disease concern low P2 amplitude. This P2 wave may be so reduced that a dip appears between P1 and P3 waves. In nutritional amblyopia, the amplitudes of pattern ERG, pattern VP, flash VP waves are smaller than normal, what corresponds with low visual acuity. Similar, partly reversible concern toxic neuropathy. Notice the improvement of visual acuity. Here it was at the beginning, and after 5 months after withdrawal of ethambutol. And look at the improvement of visual field and improvement of pattern VP amplitudes. See here at the beginning and after withdrawal of ethambutol. And also we see the improvement in flash VP. Toxic neuropathy may cause permanent visual defect, like in this case of a young man. He reported visual loss after a few weeks of permanent computer work during days and nights, insomnia, and energy drinks intake. In flash VP, P2 is very small, which suggests that the lesion is post-chiasmal, maybe cortical. ERG was normal, and you see the changes are stable even 16 months after the first signs, and visual acuity is low, and central scotoma is seen in both eyes. Optic neuropathy caused by methanol, tobacco, and ethyl alcohol gives signs of anterior visual pathway lesion. Compare this type of lesion to lesion in posterior visual pathway. And finally, what about visual problems laying outside V1 area? This lady reports no light perception of her left eye in spite of the fact that flash VP is close to normal with only lower P3 amplitude. There is no pattern VP. Theoretically, the patient should have at least light perception, but she hasn't. The second lady behaves like a blind person. In her MRI, generalized cortico-subcortical atrophy, encephalomalacia with cavities, and angiogenic demyelinization were found, but optic nerves were normal. And it isn't optic atrophy. P3 after right eye stimulation is quite good, but after left eye stimulation is low. The patient may not use the left eye because of cataract, but in the matter of fact, she doesn't have functional vision at all. It's not optic atrophy, it's a problem with perception outside the primary visual cortex. Low vision may be caused by abnormal function of numerous visual areas, which may be indicated by VP examination. Here, in Alzheimer's disease, you see very low P2 amplitude. But apart from it, the patients may be blind because of insufficient high visual functions without obvious abnormalities in VP, like in this example of no light perception, in spite of quite good flash VP with all waves and even P3 wave. And there is something we cannot explain. The diagnostic traps of VP. We should remember that a pupil narrower than 4 millimeters causes delayed latency and decreased amplitude of waves of flash VP. Abnormal pattern VP may be caused by uncorrected refractive error or patients in attendance. Delayed latency of P100 of pattern VP may result from optic media. Delayed latency and decreased amplitude of P100 of pattern VP may result from macular diseases, and it's very important because it's a problem for neurologists. Ophthalmologists may examine the macula and may exclude macular diseases, but neurologists do not. Take-home message. Cortical response comes from retinal activity. It means that VP arises from ERG. VP are not specific. Tumor must be excluded by MRI. Pattern VP and flash VP should be combined for diagnosis. Multi-channel stimulation is very useful for localization of the lesion. Vision has to be conscious, and it's crucial. We have to know that we have vision. And do not forget about amblyopia. But visual pathways in amblyopia is another long, fascinating story. Thank you for your attention.
Thank you very much, Professor Wilczek. As we could realize in the speech, in fact, if you think about all the electrophysiology tools, so VEPs, ERGs, you can imagine how powerful tests this electrophysiology tests represent. In fact, you can diagnose or help in diagnosis of various different disorders, not only in eye itself, in whole visual pathway, associated brain regions, some toxic situations, toxic neuropathies, which is, in my opinion, quite unique. Also, in my opinion, what is unique, which I mentioned in the live chat, this is fully translatable examination. And if there are any basic scientists who are listening us, we know that we apply all these tests also in animal research for our animal models. And in fact, when we describe all these waves in VEPs or ERGs, they don't differ so much from this which we describe in animals. Of course, the voltage of these waves are different, but also in animals, we use it to detect some abnormalities or effects of our treatments, which is, in my opinion, really kind of reliable, because there is not so many tests that we can apply in both animal models and in people in diagnostic of human diseases. Electrophysiology is one of these tests which we can fully take directly from basic research to the clinic and vice versa. So that's why I decided to include this electrophysiology tests to make everyone realize how important these topics are. They are not easy in both animals and human. They require years of experience to be able to notice and to interpret all these tiny little changes in the waves. But I think that this is one of these tests which are truly reliable. So
I think we may learn a lot from animal models. I worked on rat model years ago, and some changes after some neurotransmitters we put into brain in rats. Some change I can find in patients, and I have some doubts that there is a truth they didn't take anything more than only energy drink or something more, because we studied changes in VP after stimulation of opioid receptors and so on. So we know that it may be changed, and I think it should be evaluated for next years.
do you think that in such, let's say, well-developed method, which is electrophysiology, there is still some space for some new discoveries, some new markers, maybe? We can hear a lot recently about scotopic and photopic negative or positive responses, for example. Do you think this is something really new and useful?
I think it's always something to do, something more. We are not sure what is origin, what is from which part of visual system originated some waves, and what there are a lot of various visual problems and new visual problems which may be connected to high visual functions. And there are problems with therapy of vision with after brain lesions and congenital brain lesions. And I think it's a lot of problems to evaluate it, and it's very interesting, but I don't know how to tell how that person can see, or why it cannot see. Sometimes it's very, very difficult to tell. And I believe in functional magnetic resonance imaging, maybe connection electrophysiology with this method may explain a lot of our doubts.
Thank you very much. So, dear participants, the chat is open, so you can leave your comments, and if there are any comments, we will answer them in the chat. And also, you can freely contact us in both emails. The seminar will be available on YouTube, so please share it, and you can still access it from the NeuroEYEscience channel. And from our side, I would like very much to thank to Professor Wilczek for this very detailed lecture. And I would like very much thank to everyone for attending. And have a nice day or evening from